Kelley, thank you for coming back again and doing round two of SMART trials. So please, we'd love to hear what you have to say.
Great, happy to be here. Let me share my screen. Yeah, I'm Kelley Kidwell. I'm a professor of biostatistics at the University of Michigan, and I specialize in smart design. And so, as Dan just mentioned, I talked, I don't know, a year or more ago of an intro to smart design, and I'll try not to repeat myself too much and go more into how you can use that for longitudinal treatment effects. I think it's really hard to follow Frank and Emily and their amazing thought-provoking talks. This is drilling down into very specific design and analysis, but hopefully you could walk away with some actionable sort of methods and design to input if interested from this. And so just to motivate smart designs a little bit. So often in many diseases and disorders, especially those which are chronic, but also those which are acute, and not only for diseases and disorders, but also thinking about education initiatives or implementation science initiatives. It's not just a one and done process, right? Usually there's treatment over time or the intervention may be implemented and it doesn't work for all, or not everyone's adhering. There could be some burden for it. And so as we can see in this picture on the right, this is looking at like a treatment disorder or disease over time where there could be treatment applied, you may get better, but then subsequently over time, you may need to be treated again. So since there's usually not one size fits all and potentially issues with like adherence and burden, we want to be able to have sequential intervention strategies that we can propose, and ultimately that full strategy will affect the outcome, not just the most recent treatment. And so when you think about those sequential treatment strategies, we've in the statistical world seen them dynamic treatment regimens or dynamic treatment regimes or adaptive interventions. There's lots of different kind of fancy titles we put on these, but essentially they're just the way that treatment is practiced most of the time, such that we can specify these individually tailored decision rules that can alter based on response or adherence, and that therefore that treatment can change over the course of care, prevention, implementation, or education. And the idea behind this is that it's not just like, we put this together based on our opinion or based on experience. It's really that we've got evidence, robust evidence for this treatment guideline that is affecting the overall outcome. And so we want to operationalize this sequential decision-making to improve clinical practice or improve implementation science or education practice. So here's an example that I'm going to come back to at the end. This is one dynamic treatment regimen specifically to prevent college drinking. So it's to send some personalized normative feedback and ask the individual to self-monitor drinking in bi-weekly survey prior to the start of their first semester. For those who report heavy drinking or high intensity drinking in the first semester, they'd receive an email invitation to an online health coach via a secure chat. And if they don't have heavy drinking, you just continue the self-monitoring. This is all packaged into one dynamic treatment regimen. What do we do first? How do we measure if that's doing well or not? And what do we subsequently do for those who are doing well? And what do we do for those who aren't doing well? And so that way we can contain these multiple treatments or interventions in the sequence. And while two participants or two individuals may respond differently, they'll get different treatments all under the same protocol. We've got, upfront, we've got it figured out what's going to happen along that course of care. However, right, because we've got what do you do first and what do you do subsequently, and maybe even how do you measure a response, there's lots of questions that we've got to figure out and provide evidence for to develop these evidence-based dynamic treatment regimens. And so one way to do that is through these sequential multiple assignment randomized trial designs, or through SMART design. A SMART is a multi-stage clinical trial. Each stage corresponds to a critical decision point. What do we do first? What do we do for those who don't respond? What do we do for those who respond? And at these critical decision points, randomization takes place such that we can provide that robust evidence for that treatment sequence. And one individual in this clinical trial will move through all of these stages or all of these critical decision points in the trial. And again, these smarts are really motivated by the fact that we want to inform the construction of these dynamic treatment regimens. It's that we want to get that robust evidence for that entire treatment sequence, not just that sort of standard clinical trial framework, which says at this point in time, is A versus B better? At this point in time, is C versus D better? Well, it's great to know that, but what if A and C interact, right? How would we get to that? Only if we study it within the same trial and within the same people. So here's an example of a smart design. This is the most commonly used smart design, where individuals are initially randomized across two treatments, A versus B. And then over time, or at some point in time, some intermediate outcome is assessed. This I'm calling response here. It might be based on adherence. It might be based on patient-reported or clinician-reported outcomes. Dependent on that response, then the second stage can differ. So for those responders, they might just continue, or maybe they step down their initial treatment. Whereas non-responders may be randomized across maybe intensifying the initial treatment and or adding on or switching to a different treatment. So I've got, the treatments here as A, B, all the way through H. They could all differ. They could also be repeated across the first and second stage, and they can be repeated across the non-responders or responders. They don't have to differ. I've just made it as generic as possible. Now, within the smart design, we have these dynamic treatment regimens embedded within it. So here's an example of a dynamic treatment regimen that may be of interest. First, start with treatment A, and if you respond, receive C, and if you don't respond, receive D. Right, that dynamic treatment regimen doesn't include randomization. It's the treatment protocol or the treatment guideline that I want the robust evidence for at the end of the trial. The smart design includes the randomization to provide that robust evidence. And in fact, in this most commonly used smart design, there are 4 embedded dynamic treatment regimens, which I've outlined to the right here. 2 that start with treatment A and that differ for the non-responder treatment, and 2 that start with treatment B and again differ for the non-responder treatment. But each of these dynamic treatment regimens includes 2 pathways in the smart design, such that we know from the start, what do we do for those who respond and what do we do for those who don't respond. Now, smarts have been used across a wide variety of fields. They sort of started in the oncology space because it was very natural to think of a sequential treatment. But they've subsequently been used much more in the mental health and education space, and they've been, in the last decade or so, more and more used in implementation science. This is just a subset of areas in which smarts are used, and you can find some really great resources at the D3 website, which is linked here, and slides will be available for those interested. And the reason why they're used in so many different fields is because they can answer so many interesting questions. Of course, they can't answer them all at once, but they can answer questions such as what should you get first versus what should you get second, and does having those in the treatments in that order affect the outcome? It can also answer questions about when should we change treatments? Should it be earlier or should it be later? And what definition should we use to figure out if you're responding or not responding? We can also answer questions about can we further personalize these treatment sequences? Are there specific subgroups of individuals based on patient and or clinical characteristics or site level characteristics that certain treatment sequences or intervention sequences will work best for? Now, when we often think about smart designs, or when you first get introduced to smart designs, the primary analysis which is introduced is the end of study analysis. So we think about, well, there's some outcome measured at the end of the second stage, this end of study outcome, which I'll call Y, and we're going to see how that entire sequence affects that outcome. And or we can answer questions about well, what do you first start with, averaging over subsequent treatment? And for this, the most commonly used method is what we call weighted and replicated regression. And I talked more about that in my first talk, and so I won't spend too much time here going over it, but there are excellent resources if you're interested in learning more, and I'll touch slightly on it as we move forward. But what I want to spend more time today is talking about, well, what if we have longitudinal data, which we often collect in clinical trials? How do you take advantage of all of those outcomes measured across time instead of only focusing on that end of study outcome, which we know can be less powerful and less informative than thinking about the entire trajectory? And so instead, if we think about, some outcome of interest that could be measured at baseline, at the end of the first stage, maybe the end of the second stage, and maybe a longer term outcome. Dan, do you have a question? Maybe an inadvertent hand raising there. I'll let you speak up.
I apologize. It was an inadvertent hand raising.
No worries.
Equivalent of a butt dial. I'm sorry.
No worries. It was a exciting. We'll take it as an excitement of hand raising. Like, oh wow,
I am getting very excited. Yes,
yes.
absolutely.
Okay. Well, then in that case, we'll continue with, what if we have this longitudinal data? How do we use it in the SMART framework? And so just as when you have longitudinal data in a standard clinical trial, right, there's lots of really interesting estimates and inferences that you can have using that data. So we can examine the pattern of change in the dynamic treatment regimens. We can compare the average outcome for the dynamic treatment regimens over the study duration. We can look at both short-term and long-term differences in the outcomes, and we can figure out whether those differences between the dynamic treatment regimens stay the same or if the outcomes converge. What's really cool about this too is that we can identify these inflection points where maybe it would be best to add treatments into the sequence, or where response could be assessed earlier within those dynamic treatment regimens. And something of interest specifically in the oncology world now, and I've been talking about at recent FDA and American Statistical Association meetings, they're interested in, if we have this of thinking about the sequence of treatment and like how each part of that sequence is affecting the outcome over the trajectory. So if we have, prior to surgery and then post-surgery, how are those components adding together? If we have some initial treatment and then maintenance treatment, how are those components adding to the effect, the overall effect? And so we can do this within this longitudinal setting. Now, a naive approach to a longitudinal analysis in a SMART design would say, okay, I'm going to take what I would do if it was not longitudinal, where I probably should have put this on the slide, but A1 is the indicator for the first stage treatment and A2 is the indicator for the second stage treatment. And usually our analysis would say, I'm going to see the first stage treatment effect, my second stage treatment effect, and the interaction between them. And so a naive longitudinal analysis would be, well, let's add time to that equation. And if you did that, you get some trajectories that looked like this. And at first glance, it seems, well, yeah, you've got, say, for example, that most commonly used SMART design. They have 4 embedded DTRs. Look, I've got 4 trajectories right here. But this is an inappropriate analysis, because if you think about the SMART design, 2 of those of those 4 DTRs, 2 start with A1 equal to 1, and 2 start with A1 equal to, say, -1 if we use this contrast coding. And so if they have the same first stage treatment, those trajectories need to be the same within the first stage, right? They can't be separated out in this first stage. And so that needs to be taken account of in the analytic approach. So instead, we need to use these piecewise regression models when we're thinking about the longitudinal analysis of a SMART design. And so we've broken down the model into the time in stage 1 and the time in stage 2. And when you're in stage 1, right, the only effect can be of that first stage treatment. Whereas when you're in stage 2, you can have an effect of the first stage treatment, an effect of the second stage treatment, and there can be this interaction, whether it's synergistic or antagonistic effect that's happening in stage 2. And so then more appropriately, you get these trajectories that could look something like this, where you've had to, again, account for the fact that you really only have those 2 treatments in the first stage. Now, the most commonly used method of analyzing longitudinal data is again using this weighted and replicated regression with this piecewise regression. And we use generalized estimating equations in this context to estimate our coefficients. There has been some more recent work on mixed methods in smart designs, but it's yet to be published. So we'll all hold our breath for that to come out soon. But for now, we can use this weighted and replicated regression where we replicate those observations which are consistent with more than one DTR. So in that most commonly used smart design, those individuals who are responders are consistent with a DTR where the non-responders get one treatment and the other DTR where the non-responders could get the other treatment. And so we have to replicate their data. And this is essentially just a trick for the software so that we can use them to estimate both DTRs. And then we have to say, oh, but software, they're not actually different people, right? So let's fix that variance by using the robust sandwich estimators. And then we also weight the data to account for that imbalance by design, the fact that the non-responders were re-randomized in the second stage, but the responders were not. So if there's any of this imbalance, then we generally use inverse probability weighting, where we'll weight by the either the known or the observed probability of being on your pathway. And if we do this, the reason why this is the most commonly used form of analyzing data from a SMART is because we can use pretty much standard software packages to do this. In the non-longitudinal setting, it's a very simple standard implementation where we've just done some data formatting for the replication and the weighting. And in the longitudinal setting, there's a little bit of a fix to the standard software, but it's really quite easily implementable. And that fix has to do with the variance. So I won't go into the estimating equations, but if you're curious and learning more, I've linked a bunch of papers where you can really look into the theory behind why these estimating equations are appropriate, and will provide unbiased estimates for coefficients. So what we have to do to the software is to account for the fact that if we're going to use a non-independent working covariance matrix, which would most likely be appropriate because we would think the longitudinal data would be correlated, then we just have to revise the correlation matrix in the standard software because of the smart design, because of the fact that we have replicated data. The responders are replicated. And so we want to say that we'll have this block matrix that we'll just have to specify in the software to say the upper block will account for one set of responders and all the non-responders, and the lower block accounts for a second set of responders. But they're independent of each other there. And that way we can specify any working correlation matrix that we want to within that block matrix there, right? We can have autoregressive, we can have exchangeable, whatever you feel like is most appropriate for your data. Now, if you're interested in using a longitudinal SMART or SMART in general, thinking about power and precision of such a study, the first and foremost, it comes down to what is your hypothesis? What is your main objective of the design? And what is your outcome, just like in any trial? And so often smart designs, while motivated by the dynamic treatment regimens, are actually powered on differences between the initial treatments. And we call those a main effect question. So like, what's the difference between starting with treatment A versus treatment B? And that might be analyzed at the end of stage 1, which would be the cleanest analysis, or it might be averaged over the second stage treatments. Alternatively, you might say in those non-responders, maybe the treatments are the same in the second stage, or the strategies are. Is it better to increase the initial treatment or add on a different treatment? And so you might power on those questions. And in that case, the power or precision of the effects is really similar to a standard trial, and it's dependent upon your outcome type, your effect size, the variability, the type 1 error. And if you have longitudinal data, the correlation between those longitudinal measurements. Of course, if you're also controlling for baseline, that can help with the precision as well. Alternatively, if you have enough preliminary data on the dynamic treatment regimens and you are powering or trying to, just as we learned with Emily and with Dan, and with Frank, maybe power and the specific hypothesis is not appropriate. We should focus on estimation, right? If we're focusing on the precision of these dynamic treatment regimens, we have all those standard considerations of the effect size, type 1 error, correlation of longitudinal measurements, but then we have to have these additional assumptions of specific to the SMART design. So what is the expected response rate of the initial treatments? And of course, how many dynamic treatment regimens are you interested in, either comparing or estimating? And obviously, as that number increases, we'll likely need more individuals in the trial. So there's a lot of really great freely available code out there. There's also sample size applets if you're interested in powering on dynamic treatment regimens for continuous outcomes, binary outcomes, and count outcomes. There are also really nice tutorial papers specifically implementing the weighted and replicated generalized estimating equations approach to analyzing the longitudinal data in SMART. Again, all of these links will be available to you. The slides will be sent out to you so that you can have these at your fingertips if you're interested in implementing this. I just want to spend another few minutes. So you've got that SMART design, you've got the longitudinal data. You maybe are going to estimate the model, this piecewise regression model using weighted and replicated regression. But what are all these different estimates that you might be interested in with this? And there are multiple given the longitudinal data. So you might be interested in the mean effects of the dynamic treatment regimen, say at the end of the second stage, or longer term outcome. You could be interested in change scores. We often see that's an interest of physicians and clinicians. However, if you've heard any of Frank's previous talks and or read his blog, you'll see why that's a bad idea. I suggest you go to his informative website to read about why maybe that shouldn't be the case. And instead, you can think about the means at different time points. Alternatively, you could think about the trajectories and the slopes, either per stage or over time for treatments or DTRs. With longitudinal data, you can also think about the area under the curve for the entire study population, entire study duration, and or divide by that by the units of time for an average outcome per unit. And I'll show you an example of why that might be of interest. So to first talk about those time-specific outcomes, you could be, again, interested in those DTRs maybe at the end of stage 2 or a longer-term outcome. And those can answer really interesting questions like, does one dynamic treatment regimen lead to higher outcomes at some specific time than another DTR? And so you can use that longitudinal data to help with the estimate of those specific outcomes instead of only using, the outcome at that one time, right? We'll have a more precise estimate if we're able to model that full longitudinal data. Alternatively, you might be interested in slopes. And so you can look at the contrast of slopes, and that will tell you if the change over time differs between the dynamic treatment regimens or the rate of change. And this can be really useful in terms of seeing if adding a treatment at a certain time changes the trajectory overall for a group under that DTR. And so, it can be really interesting to compare the slopes in the first stage and then the slopes in the second stage. And that can be really useful in thinking about the treatment stage specific effects. The area under the curve will quantify how much outcome was achieved over the course of the entire study duration. So for example, you can also take an average of this such that if you looked over a year, you might have the AUC over 12 months, which would be the average monthly outcome level over the entire study duration. And this can answer questions such as which dynamic treatment regimen maintains the highest outcome levels over time, not just at the end of study outcome. And this can be really useful if you're interested in evaluating closeness to target. So thinking about diabetes outcomes or blood pressure outcomes, how close were we to an AUC target, or how close were we to a blood pressure target over the full time? This type of outcome might be really useful for that type of analysis. And that can be calculated with just very simple geometry once we've got the trajectory. So to end, I just want to show you these in practice and give you a really nice paper to use as a framework if you are to implement one of these trials and to be so lucky as to run them and publish on it. I want to show you the results from the Enbridge study. This was a SMART supported by NIAAA. It was a R01 funded by the NIH, and their goal was going back to that dynamic treatment regimen estimate example in the beginning, was to develop preventative DTRs for incoming first-year college students as a bridge to interventions to address risky alcohol related behavior. And so the primary outcome was binge drinking frequency, and they enrolled 891 college students. This was, I've got the link here to the primary results paper, which then links the protocol paper if you're interested in learning more. One thing I want to bring to your attention about the SMART, which is somewhat unusual, but often really of interest to those who want to run a SMART, especially to clinicians and scientists, is that it has a full control arm. So that's usually when we think of SMARTs, they're all active treatments, but this one actually has a full control. They have a 1-to-1-to-1 randomization with control, and then what's again interesting about this SMART is the initial treatment actually doesn't differ. Their randomization is to whether they sort of assess the effectiveness of that initial treatment, the personalized notification prior to the first semester or during the first month of that first semester. So this is another really cool thing about SMARTs, is that you don't have to have multiple intervention types, or that might not be the question of interest. It might be that you're really interested in when is the best time to measure if this intervention is working or not. And so that's really neat about this SMART design, to show other variations of SMARTs that can include a control and can include randomization to different timings of that intermediate outcome of being assessed. So this SMART had 3 trial objectives, and these are really kind of like standard SMART objectives when you see them in the field. The first one was to compare the longitudinal outcomes between those randomized to any dynamic treatment regimen versus the control. So if we go back here, it's essentially looking at all 600 of these folks to the 300. So we've got a SMART, but our primary question that's going to power the trial is like a 2-arm randomized control trial. And then their secondary question is about comparing the outcomes of the embedded dynamic treatment regimens. And their third objective is to examine some predefined moderators of the intervention effects. And then whenever I write a grant about SMARTs and or write a paper about SMARTs, you always want to show the SMART figure, and then you want to have a table that outlines the adaptive interventions or the dynamic treatment regimens that are embedded in those. And you say, well, what's the initial treatment, or what's that initial timing that differs? How do you define response? And then what happens for those who respond and what happens for those who don't respond? And always toggle back and forth between that table and what the DTRs are versus the design. And so then they're saying, and look, this DTR, this adaptive intervention, are the subgroups A plus C or B plus C. And so that really gives readers the knowledge of what are DTRs versus what is the SMART, right? The DTRs are the treatment guidelines that include 2 pathways, and the SMART is testing, or is going to provide that robust evidence of that. So then the next question is, oh my gosh, this SMART design has so many branches. How do I even think about a consort diagram? Well, it's long, it's big. And here's how they did it. They kind of have it in 2 steps, which is the control versus any DTR, and then sort of within the DTRs, what was the fallout of the numbers there. The first aim, again, is like a standard 2-arm trial. Let's compare everybody on control versus anyone who got any DTR. And so this was a standard longitudinal model. They went with generalized estimating equations because that's what they were going to use for the DTRs. And then they show the estimates of the proportion of, actually, I think this is, their outcome ended up being like I think it was a ratio of ratios, which isn't the most clear, but they're showing that between the two groups at baseline, so the control is a circle and the treatment or any DTR is in a triangle. At baseline, follow-up 1 and follow-up 2. And what you can see here is that unfortunately, there was no difference in binge drinking frequency between the control and the intervention. And more unfortunately, and maybe not surprisingly, from when the participants, from when these individuals, right before they started college to when they started college, their binge drinking doubled. The AIM-2 was then based on the DTRs. And so there were 4 embedded dynamic treatment regimens in this design. And so you'll see 4 estimates across these time points of interest. And they have the legend here for those 4 different DTRs. They use that weighted and replicated generalized estimating equation, that piecewise regression that we talked about. They have their, the stage 1 intervention, stage 2 intervention, that interaction and the time and the interactions of time and interventions. They assumed an exchangeable working correlation with robust sandwich errors to account for the fact that they had that weighting and the replication in the analysis. And again, they found no difference in the proportion or in the binge drinking frequency across these dynamic treatment regimens. The last aim had to do with examining pre-specified moderators of the intervention effects. And so for this, often what we use is something called Q-learning in the SMART space, where we're interested in backward regression of finding baseline and time varying variables up to the time of stage 2 that might be associated with better outcomes for all those dynamic treatment regimens. So it's essentially just a subgroup analysis, looking at the moderators of the first and second stage treatments. And they did find some sort of interesting results there, which was the baseline intention to pledge to Greek organizations moderated the effect of any dynamic treatment regimen or adaptive prevention intervention on a change in binge drinking. And that among heavy drinkers, the resource email versus health coach was more beneficial for those who reported more frequent binge drinking. So they were able to find some subgroups which, sort of saw the tailoring of treatment might be more appropriate for specific subgroups than others. With that, I thank you so much for listening about longitudinal analysis and smart designs. I'm happy to take questions. I'm also happy if you have questions offline. My email is here. I also teach workshops via Smart Workshops if you're interested in learning more there. Thank you.
Thank you, Kelley. That was wonderful. Chris, do you want to help us with the discussion?
Yeah, I really appreciated the presentation, Kelley. That was absolutely fantastic. If you don't mind, I actually wanted to start off with a question of my own before I can run into what maybe if I've seen anything in the chat. And that question relates to the use of smart designs for observational data. To clarify, we're seeing an increase in the use of target trial emulation as a way of extracting kind of less biased data or less biased results out of observational analyses. And given the complexity of healthcare and the fact that I don't think there's any treatment that is not dynamic in some way, shape, or form, I'm curious, Kelley, if you've thought of the target trial or the emulated SMART trial.
Yeah, that's a great question. I've in the last year or two gotten an increasing amount of emails about that question and the individuals interested in it. I think what's difficult in the space of smart target trial emulation is really that second stage of how do you, right? So you've got to figure out, well, what is your population of interest and the inclusion and exclusion criteria and this response variable. And so how do you match that up in observational data to what you'd actually want in a smart design? I think is really, really difficult to get all of those pieces in the longitudinal setting. So, it's kind of easy to think about if you're looking, not easy, but it's easier to think about this point in time, A versus B, here's my inclusion exclusion criteria. Okay, I've got that. It's great. But now that we want those same individuals, we want that inclusion exclusion criteria to be similar, and we need to have this response definition that can be applied across all those individuals. I think that's really hard in in EHR records and in observational data. And so I think and it's not clear to me that target trial emulation is going to be very successful in that SMART setting. But I'd love to hear more if others have feedback.
I think the questions you're getting are probably sending people your way, because I'm seeing problems that it's very clear that there are treatment regimens that are dynamic, and people are looking at them using these target trial emulation approaches as though they are not dynamic. And in that context, I think they're producing incorrect results, if you will. And so I've been trying to push them to think about longitudinal, both for treatment and for outcome, and that pushes you towards a SMART. I'm curious, as well as kind of the thinking about the observational data and the application of a similar thoughtful process. In terms of clinical areas where you don't think a SMART trial is feasible, have you run across those yet?
For sure. I mean, I often have collaborators come to me that think they're interested in a SMART, and then when we sit down and listen to their question and what they want to get at, a SMART is not the most appropriate trial, and or there might be settings where it's not feasible or ethical due to either so a SMART design, if you want to run a SMART, right, if you're going to have that second stage of randomization, you need to have at least 30% usually of the population who could be re-randomized. So if the response rate is either too high or really, really low, and that's the group who you want to re-randomize, it's likely not a good idea to do a SMART, because you're not going to get enough data for those sequences of treatments or for all those pathways. So I've run into that setting. That's probably the most common reason why we can't do it. Alternatively, people will want to look at a sequence of treatment, but they won't have multiple options for randomization. So a SMART, right, you have to have multiple randomizations. And so if for non-responders, everybody should get, they think that, oh, well, I want to see what if we switch to this treatment. Well, unless you have another option that we can randomize to, it's not a SMART. It might be interesting, and we might be able to look at dynamic tumor regimens, but it's not a specific SMART if we can't randomize across. And so that's another reason why the feasibility might not be feasible, because there might not be enough options there. And I guess the third reason is these have been more often applied to behavioral or implementation or education interventions recently, because it can be really difficult to have various drug companies agree to participate in the SMART if you're looking at medications or drugs being compared and sequenced. The FDA still doesn't know how to deal with regimens. I've been working with them. I've been trying to disseminate this and get more interest, but it's still confusing for them to think about that. And so pharmaceutical companies and companies with drugs may not play ball because they don't know how it's going to go.
Yeah, we experience similar challenges with platform trials, with multiple drugs coming in, and the complexity of working with what seem to be competitors, but they're not really. They're all part of the landscape. I'm really curious, as you heard Frank's talk at the beginning, as he was kind of probing people on what questions you should force an investigator to answer during the design stage. As you listened to that, what did you think was missing for a SMART trial?
Oof. Well, I first have to admit that unfortunately I missed that part of.
Oh, I'm so sorry. I'm so sorry.
I missed Frank's talk mainly because I was actually presenting to the FDA. Otherwise, I would not have missed it because it was such a great talk. I did get to see the the slides. What I will say that we have to ask for at the design stage for a SMART that's not standard is, well, what do you think that the expected probability of response is to the first treatment? Because we need to have estimates of who's being re-randomized to see if, one, the design is feasible, and two, if there's anything to do with powering precision around the dynamic treatment regimens, we need those. And if there's also power or precision around the DTRs, we need to have some idea of the effects of that full sequence. And that's often not well known prior to the SMART unless there's been a lot of preliminary study work done. And so that's the reason why SMARTs, while motivated by dynamic treatment regimens, will actually focus on those stage-specific questions for power because they have that data at their fingertips.
So maybe I could throw this at Frank. Yeah, I was going to throw the question to Frank and say, now you've heard the second two talks. What did you miss?
Well, I don't know in terms of miss. I was thinking about your question about which other questions to ask. And I mean, the fact that you're depending so much on longitudinal changes, and some of them can occur pretty fast, is a little bit unique to the SMART trials. And also, Kelley also mentioned the most important thing is what's your response rate in that first thing. And the one question I have about all of this is I always think of response as a matter of degree. And so could you envision any sane design where you might be having re-randomization at different times for different people depending on their degree of response?
Yeah, so Frank, your question gets to one of the questions that I was going to pose to both you and Kelley, which is, you demonstrated that a binary outcome is less powerful and typically uses more people. And for a SMART trial, almost by definition, the outcome for at least at the first stage needs to be a binary outcome. And so I'm curious. I think you asked the question in a much smarter way, which is outcomes are continuous and they're on a degree. And so how do you take that into account in designing a SMART trial? And is it possible to have people starting at different levels?
Yeah, absolutely. This is a great question. And I have several answers for it. One is that that intermediate response, right, where you re-randomize doesn't actually have to be the same as the outcome of interest. So you can collect a different continuous outcome at that time point and that other time points that you can use in your analysis, and that dichotomous, the binary version, is just used for the design and the re-randomization or a decision point. Now, so that's one answer that's maybe not the SMART answer because you can still have that same argument. But that's one thing. Second is we've actually had, we've come out with alternative for SMART design, which we call, instead of, usually you call that response variable, a tailoring variable, and it's most often dichotomous, but it doesn't have to be. It could be it could be an ordinal variable too. You could have 3 levels, whatever. Alternatively, you can have what we call a tailoring function, which is a continuous outcome, and you can randomize on that function. And so you could put, various functions on that continuous variable to say, well, if it's on, these levels, we've got higher probability of continuing, or these levels, more probability of randomizing, et cetera. So we do have papers where you can use that. Alternatively, you could re-randomize everyone. But if you want to use some sort of information in a continuous variable in a more informative way, you can use what we have as this tailoring function, as opposed to a dichotomous variable.
Hey, Kelley, can I ask, why isn't that the standard?
Well, I guess I don't have, I'll say what maybe I think, but I could be totally wrong. SMART designs, really came out in like the 90s, and seminal papers from Susan Murphy, Dawson, and Lavori, which proposed this sort of design where it's this dichotomous endpoint of response and non-response. And I think it was probably pushed from clinicians who wanted to see decisions sort of in this binary, well, I think of people as doing well or not. And it was also probably primarily pushed from the oncology space, where it was like, well, we see tumor response or non-response. And that's how we define it in clinical oncology. And so that's going to make it easier to decide whether they need maintenance treatment or something else. And then that kind of just stuck. But it would, and we developed the theory for this tailoring function. I haven't seen it used in a trial yet, but I have seen 3 or 4 like sort of ordinal value response used in a trial. But it would be interesting to see the smart world go that way.
Yeah, I also wonder if there's like maybe some concern about like correctly specifying like the functional form of response. Like that's a decision you have to make, and like some sort of modeling complexity probably that goes along with it. But it seems like a more appropriate way to think about it as opposed to arbitrary threshold.
Yeah, I mean, alternatively, you might think, well, if it's really patient-centered, you maybe want to, even have that intermediate point be really, well, what do you want now? Do you want to continue or do you want to change? That might be the more appropriate / patient-centered, and what would happen in the real world is this shared decision-making and the patient and the clinician of what to do going forward. And that can help with adherence and provide more useful estimates. That's also often done.
I love that this conversation is really pushing us to really think about patient-centered design, patient utilities, patient outcomes. I heard Frank talk about that at the beginning. I know Emily talks about that a lot, so I really appreciate that. Something else that happens in trials is we lose data, and data go missing, or we don't collect it. And so one of the questions that is in the chat is, how do you handle the missing data, particularly if you have missingness on the first stage outcome?
Yeah. So if the first stage outcome is missing, usually what happens is you define those individuals as non-responders. You give them a second stage treatment assignment, and you would analyze their data as intent to treat. You hope to collect the outcome, however, that's likely also missing. In which case you could use either multiple imputation for smart designs. There's a really great paper from 2012 or 2014, short read, Labor, Murphy. There are 3 of the authors. There's also a 2019 paper by Eric Labor, is one of the authors that's using inverse probability weighting instead as sort of like a double robust approach for the missing data. Either of those would be the most commonly used forms of dealing with the missing data, and those appropriately account for the stages of the trial and the missingness that can occur at either stage and or the intermediate outcome, and will appropriately provide you with estimates at the end for the dynamic treatment. I'm happy to share those if someone, whoever put that in, if you can't find those papers, I'd be happy to follow up and send them to you if interested.
And the second part of the question is, what is the rational choice of the variance covariance matrix in the GEE approach?
Right, so in some sense it's a working covariance matrix, so it doesn't have to be correct, but you can gain more precision if it is. In the longitudinal setting, I guess it would be as usual, like, what do you think is the relationship or the correlation between the longitudinal outcomes? So do you think that it's a decaying correlation? Do you think that it's the same correlation, right? You would use that as if it were sort of any standard longitudinal trial, that decision.
Kelley, those papers you were just referencing, can you just send them to us, and we'll put them with all of the presentations on the website. That way everybody has them. It's a living resource.
Absolutely.
Thank you.
My last question is a really naive one, and it's I think maybe it's for you, Frank. Thinking about your approach to longitudinal outcomes and measuring over time, and that smarts by definition occur over time. do the methodologies that you're referring to actually provide an approach to analyzing smart trials where you don't necessarily have to randomize at a single point in time. The dynamic treatment can be some kind of a let's say time varying covariate. And then you can adopt randomization in there at appropriate points when necessary. So I'm curious, if you had a large cohort and you started them on a trial and you used the approach that you were taking with this longitudinal ordinal outcome, and then at certain points, people just changed treatments, or you had a new treatment came on the market and you want to do a nested randomization, if you will. Could you borrow some of the thinking that Kelley's got around smart trials, apply it to your modeling, and come out with an answer of how to answer questions about treatments in a dynamic regime?
I think it's a wonderful question. And just briefly, there's like three methods people use a lot for analyzing longitudinal data. There's a GEE approach, there's formal modeling that's very parametric for the correlation structure, and then there's Markov models. And what we used in COVID that Chris was alluding to was Markov models. And I think they do have an application here because with Markov models, whether you're dealing with a regular like binary state that a lot of people are first introduced to state transition models with, or you're dealing with ordinal or continuous, it's very easy to have time-dependent covariates in a Markov process. And then that could be time-dependent treatment, but it could also be when you're conditioning on the previous state to get your state transition probabilities, you might imagine that in the first stage there was a partial response or a super good response, and that might affect the trajectory in the second stage. So you can condition the trajectory, the later trajectories on some of the initial trajectory stuff. And then when you get your state occupancy probabilities, you marginalize those out to get back to the intention to treat estimate. So I think there is a possible application there.
Yeah, I just wanna add that right in all smarts, you don't have to have a specific randomization point. That can vary across participants and across time. So that is already being done in smarts where you can have dynamic seconds. The start of the second stage can be dynamic per individual.
That's great. Dan.
I had a question for Emily, actually. You gave some two nice examples in the recovery and remap trials of learnings in networks that were set up. One was a healthcare delivery network, and the other one was I think a pulmonary network, where they asked a number of questions in sort of a platform design. One of the failures, though, in the COVID trial was not considering the role of time in initiating treatments, and the recovery trial came to a neutral result for the effect of high titer antibodies on COVID. But when applied much earlier, there was certainly a substantial effect. So I'm not sure how in your construct we deal with the problem of the at-risk population, and are you getting does your prior information capture the time frame in which you might modify risk? And how would we do that with your meta-analysis type approach?
Yeah. So if I understand the question correctly, it's really, these interventions are stage dependent, right? I mean, and that's, true for any sort of system that is intended to evaluate sort of multiple therapies over time. And, our trial designs aren't always kind of aligned with that.
Yeah, using a network that pre-existed to be in the intensive care unit, a priori defaulted the early COVID patient out of the at-risk population to test the plasma. And yet that was the vulnerable population, the outpatient,
Right.
not the ICU patient.
Right. I mean, I think, I'm not sure there's like a clear answer to what, could have been done differently. I think, the high level thought is like, well, time needs to be represented in some way, as, a kind of core design variable, that has, implications for eligibility and kind of how we stratify and define interventions. And I think what you want to avoid is this sort of averaging over time that makes it difficult to, see those differences. So I'm not sure if there's like a clean way to think about what could have been done differently, but I think sort of explicit modeling of that time variable is one way to, at least incorporate it to some extent instead of kind of forcing some single summary effect or something like that.
Thanks. I think that's a good point. And maybe using Frank's, let's just sit down and talk about what you're trying to do
Yeah.
and who you're trying to help. Uh, Maybe a good start in your program as well.
Right.
So I
Chris, do you
don't
want to sum
see,
up?
I don't see any more questions. I want to say thank you very much to three wonderful presenters. Really, really enjoyed it. I learned an awful lot. Thank you so much for sharing your expertise and wisdom. And mostly, thank you for breaking down really complicated topics into things that I could understand. That's always the most useful. So with that, thank you very much indeed. And we look forward to the next DIDACT. Dan, is there anything else that you want to mention?
Nope, I think you summed it up beautifully. We're very thankful, and they were wonderful presentations.
These were super talks, and I do want to put Emily on the spot for 1 minute.
Please.
Emily's stressing continued learning and learning longitudinally over time. Clinical trial data is the most expensive data that we collect and the highest quality, and it's not shared well at all. If we really learned over time and made optimum use of randomized trial data that's so carefully collected, would we need fewer retrospective observational studies?
What a question, especially for the last minute. Let's see. Yes, maybe, and also definitely not for populations that are not included in clinical trials. I mean, some of it depends on how we design those trials, the interventions of interest, et cetera. So yes. At the same time, of course, anytime you're using clinical trial data for assessment of some, intervention or risk factor outside of the, primary intervention that, was part of the randomization process, you're moving to an observational design. So you have to keep that in mind. But to the extent that, we believe the data are probably higher quality, more complete, less kind of messy and involve kind of fewer statistical hijinks to deal with, moving from raw data to analytic data that we have to incorporate for things like real world data. Yeah, I mean, I think we could be making better use of it for sure.
Thank you.
Okay.
So I think with that, shall we call it quits, Dan?
Yes. And we
Well,
want to
thank you
thank
very
our
much,
audience,
everyone.
right?
Thanks all. Thanks for having us.
Thank you, everyone.